Hello friends, today we will discuss about cardiac septal defect, their development and diagnosis. There can be many types of septal defects: atrial septal defects, atrioventricular canal septal defects, outlet septum defects, interventricular septal defects which can be muscular or membranous. Let us first discuss about different types of septal development in heart. In third week post-conception, embryo consists of three basic germ layers: ectoderm, mesoderm and endoderm. Mesoderm differentiates into four compartments: axial, paraxial, intermediate and lateral. The lateral mesoderm is involved in formation of circulatory system and viscera. Now the cardiac crescent stage of morphogenesis. In lateral splanchnic mesoderm, clusters of angiogenic cardiac precursor cells develop and migrate anteriorly toward the midline and form bilateral crescents which fuse into single heart tube. About same time, laterality is being established for entire embryo, and it includes number of signaling molecule including serotonin, which result in expression of transcription factor PITX2, the master gene for left-sidedness. Disruption of this pathway on left result in laterality abnormality, including many heart defects. Cells of extracardiac source, that is neural crest cells, also migrate in developing heart and are involved in formation of conotruncal region. Once primitive heart tube is formed, it is defined by primitive ventricular pole at one end and arterial pole on the another end. Primitive region include from caudal to rostral, sinus venosus, primitive atria, primitive ventricle, bulbus cordis and truncus arteriosus. These regions are separated by two transitional zones, AVR, future AV wall, and primary fold, which is future interventricular septum. Primitive heart tube shows peristaltic movement, and with growth, tube undergoes looping by folding on itself, causing heart to assume its normal position in left thorax with atria posterior and ventricle more anterior. Failure of heart to loop properly results in dextrocardia and heart lies on right side. After looping, several transitional zones can be identified, separating the primitive cardiac channels. Sinoatrial link between sinus venosus and common atrium, AV link between common atrium and common ventricle, primary fold between primitive left ventricle and right ventricle, ventriculo-arterial link in the conotruncal region of outflow tract of heart. How the interatrial septum is formed. Septation of atrium starts at the end of fourth week post-conception and completes after birth with closure of foramen ovale by 6 months to 1 year. A wide communication called foramen primum is seen between primitive right and left atrium. Septum primum grows from atrial roof to almost completely close this foramen primum. In middle of septum primum, perforation appears called foramen secundum. Septum secundum grows from atrial roof along septum primum to partly cover foramen ovale. Lower limb of septum primum continues its growth and upper limb regresses. Boundaries of foramen ovale are now formed by upper limb of septum secundum and lower limb of septum primum. Abnormalities in atrial septum can vary from total absence to small opening after birth called patent foramen ovale. There may be premature closure of foramen ovale before birth. As a result, right atrium and right ventricle undergo great hypertrophy while left side remains underdeveloped. Now the AV canal septum formation. It begins at the level of AV walls and ends at the caudal attachment apically. At the end of fourth week, 4 AV endocardial cushions appear, one on each side plus one at dorsal and one at ventral border of AV canal. Dorsal and ventral cushions grow toward each other and fuse, forming septum intermedium. Insult at this stage can cause abnormalities of tricuspid valve and mitral valve that are called common AV canal defects. If fusion of endocardial cushion is too far to the right, it causes tricuspid atresia. With tricuspid atresia, there is increased pressure in right atrium, as a result of which foramen ovale fails to close. An inlet VSD has no muscular rim between defect and AV valve annulus. Outlet septum include conus and infundibular septum in region below arterial wall and above crista supraventricularis. It separates left and right ventricular outflow tracts. VST in this region is called outlet VST or doubly committed subarterial VST or supracristal VST. During 5th week of fetal development, pairs of opposing ridges appears in truncus, which is distal one-third of bulbous bodies. These ridges or cushions, while growing to aortic sac, twist around each other, making the spiral course of future septum. After complete fusion, ridges form an aorticopulmonary septum, dividing the truncus into aortic and pulmonary channel. When truncus swelling appears, similar swelling appears in walls of conus cordis, middle one-third of bulbous bodies. These conus swelling grow toward each other and distally to unite with truncus septum. Now septum divides conus into anterolateral portion, that is outflow tract of right ventricle, and posteromedial portion, outflow tract of left ventricle. Now what are its significance and genetic association? Spiral septum may not be formed at all. This condition is called patent truncus arteriosus, or it may be partially absent, which leads to shunts between aorta and pulmonary trunk. Neural crest cells, which are ectodermal cells, migrate along 3rd, 4th and 6th pharyngeal arches to outflow regions of the heart and form endocardial cushions in both conus and truncus arteriosus. This process is regulated by SHF through Notch signaling pathway. When insult to SHF or neural crest cells disrupt the formation of conotruncal septum, defects produced are TOF, pulmonary stenosis, common arterial trunk, and TGA. Because neural crest cells also contribute to craniofacial development, it is common to see facial and cardiac abnormalities in same individual. There is also link between deletion 22q11.2 with involved TBX1 gene expressed in neural crest region and presence of conotruncal abnormalities. Now the interventricular septum formation. Muscular part is formed. Muscular part is also called trabecular part. It is the largest part of interventricular septum. It extends from membranous septum to the apex. Ventricular cavity is formed after conus and proximal one-third of bulbous cordis has merged into primitive ventricle and has to be divided into left and right ventricles in such a way that each half communicates with corresponding atrium and outflow tracts. A septum grows upward from floor of bulboventricular cavity and divides lower dilated part of cavity into right and left halves. It meets fused AV cushions, septum intermedium, and partly fuses with them. It is in fact enlargement of ventricular cavities rather than growth of septum which makes this muscular part. Cephalic margin of muscular septum is free, concave and twisted. It presents dorsal and ventral horn. Dorsal horn fuses with right edge of dorsal AV cushion and ventral horn with left edge of ventral AV cushion. An interventricular foramen appears between two ventricles at upper margin of IVS. Outgrowth of tissue from endocardial cushions in the conus and right side of AV cushions along top of IVS closes this interventricular foramen. Membranous part of IVS is small and located between inlet and outlet component and below right cusp of aortic wall. Interatrial and interventricular septum do not meet the AV cushion in same plane. Proliferation of endocardial cushions fill this space. First part, that is posterior part, separates left ventricle from right atrium, and second, that is anterior part, separates two ventricles. Tricuspid valve is attached to membranous septum at the junction of both parts. Tricuspid, mitral valve and aortic valve continuity is via this central fibrous body. Two defective membranous septum are surrounded by fibrous tissue without extension in adjacent muscular septum. Defects which involve and extend in surrounding muscular septum are called perimembranous, paramembranous or infracrystal defects. Interventricular septum defects may be seen in membranous or muscular part of septum. They are most common congenital heart defects. Now, by concluding the septal development, I want to say, inflow parts of both ventricle are formed by primitive corresponding part of ventricles. Outflow part, that is infundibulum in right ventricle and aortic vestibule of left ventricle, are formed by middle one-third of bulbous cordis. Distal one-third of bulbous cordis, that is truncus arteriosus, forms both outflow tracts, aorta and pulmonary tract. Defective formation of septa, if marked, can lead to two-chambered view called cor bilocular with one common atrium and one common ventricle, or three-chambered heart called cor trilocular with single ventricle and two atrium, or one atrium with two ventricles, that is cor trilocular biventricular. Now the diagnosis of septal defects. First, atrioseptal defect, their types and diagnosis. ASD is rarely diagnosed antenatally with the exception of septum primum defect, that is ASD type 1. Other types are ASD type 2, sinus venosus ASD, and coronary sinus ASD. ASD type 1 is also called partial or incomplete AVSD. In grayscale, it can be diagnosed by visualizing the gap in the inferior aspect of septum primum, generally accompanied with linear insertion of AV balls. Gap can be seen in apical as well as lateral four-chamber view of heart. In color Doppler, it is differentiated from dilated coronary sinus in combination with persistent left superior vena cava by flow of blood from right to left in ASD1, but from left to right atrium in dilated coronary sinus. ASD type 2, it is most common type of ASD, that is around 80%. It is located in foramen ovale and can occur postnatally when septum primum fails to completely cover foramen ovale. Prenatal size of foramen ovale varies from 3 mm diameter to 6 to 8 mm diameter at term. It is same as aortic diameter. In grayscale, diagnosis is by dilatation of foramen ovale with deficiency in septal leaflet tissues. Color Doppler is non-informative as foramen ovale flow is in right to left orientation in normal as well as defective septa. Gap can be suspected in apical or lateral insolation of heart. There is usually a family history of ASD type 2. Now, sinus venosus ASD. It is located in posterior superior, that is SVC type, or posterior inferior anatomical region of atrial septum. In grayscale, there is loss of continuity between SVC and interatrial septum. In color Doppler, flow from SVC seems to be going to both right and left atrium because of overwriting. Coronary sinus ASD is at site of coronary sinus ostium in right atrium. It is formed due to complete unroofing of tissue separating coronary sinus from right atrium, resulting in communication between right and left atrium. It is recognized by presence of LSVC. LSVC normally drains in coronary sinus, which opens into right atrium. But in coronary sinus ASD, LSVC drains in left atrium or a portion of wall of coronary sinus is patent, leading to interatrial communication. When associated with persistent left superior vena cava, it is known as Raghib complex. Redundant foramen ovale is also called aneurysm of foramen ovale. Foramen ovale flap herniates into left atrium for more than 50% or of left atrium diameter. It may also mimic coarctation of aorta due to ventricular disproportion, narrowing of aortic isthmus, and reverse isthmic flow in some cases. This is because redundant flap obstructs left ventricle filling during the diastole. Small ASD close spontaneously, especially ASD2. Larger one needs surgical or non-surgical closure. Isolated ASD has good long-term and short-term outcome. Prognosis of ASD associated with other cardiac malformation or genetic syndrome is dependent on severity of associated anomaly. Now, the ventricular septal defects. These are most common congenital heart anomalies occurring in isolation or in combination with other cardiac malformation. These can be inlet VSD, muscular VSD, membranous VSD, or outlet VSD. In grayscale, small VSDs are often overlooked but occasionally seen on color Doppler. seen in grayscale when defect is more than 2 to 3 mm. They should be seen from different resolution angles. Color Dopplers show bidirectional flow unless a ventricular pressure gradient is present because of outlet obstruction in one ventricle. Inlet VST. Inlet septum is septum between tricuspid valve and mitral valve. Gap in interventricular septum between two atrioventricular valve is seen in inlet VST. It is seen in AVST. Incidence is about 5% of all VSTs. Muscular VST. It is largest part of interventricular septum and extends from attachment of tricuspid valve to apex of heart. It is most common, that is 80% of all VST. They can be present in any part of muscular septum. They have entirely muscular borders, that is echogenic borders. With the help of color Doppler, they can be diagnosed easily. Membranous and perimembranous VST. It is most commonly seen in neonatal series, around 70 to 80%. When septum is small, it can be seen in region of alveoli, just beneath aortic valve and crista supraventricularis. When it extends to adjacent muscular inlet and outlet region, it is called perimembranous VST. It is seen in lateral 5-chamber view with ascending aorta seen along with interruption in septo-aortic continuity. Color Doppler confirms the presence of VST by visualizing blood flow shunting across the VST. It is to right in systole while main flow is in aorta and reverse in diastole. Outlet VST is about 5% of all VSTs. Outlet septum include conus and infundibular septum relating to region below the arterial valve and above crista supraventricularis. It is called supracristal, conus, infundibular or doubly committed subarterial VST. Short axis view is most informative in combination with LVOT view. It is seen as defect in IVS just posterior to pulmonary valve. Like here in color Doppler also, we can see color flow in VST. And normally here interventricular septum is intact without any defect posterior to pulmonary valve. Prognosis in VST depends on size and location of defect and associated cardiac and extracardiac wall formations. Very small VST they have very excellent outcome and 80% close before birth or within first 2 years of life. Large VST needs surgical closure, without which heart failure can occur in infant due to left to right shunting. Early repair of large VST in first year of life results in higher rate of enhanced ventricular function than repaired later in childhood. Perimembranous VST is called small when VST is less than 50% of aortic valve diameter, and it is called large if its size is larger than that of aortic valve diameter. Atrioventricular septal defects. It is formed due to AV canal defects or endocardial cushion defects. It can be partial or complete. Partial is also called septum primum defect and cleft in mitral valve with two distinct mitral and tricuspid valve annuli. Linear atrioventricular valve insertion is seen but without a VST. And it is complete when it is combination of septum primum AST and inlet VST. And there is abnormal common valve which connect right ventricular and left ventricle. It can be further balanced or unbalanced. Balanced when blood flow is equal in both right and left ventricle. Unbalanced when atrioventricular connection predominantly drains to either left or right ventricle, resulting in ventricle size disproportion. It is often associated with left or right outflow tract obstruction and found in association with isomerism. It is best detected in apical 4-chamber view. Common linear insertion of both right and left AV valves is seen at same level. In diastole, common valve is open and crux looks empty because of lack of tissue and large VST plus AST at AV region. AV length ratio is increased in fetus with AVST. Normality of fetus situs should be checked due to common association with heterotaxy. In color Doppler also, there is single channel of blood seen dividing above the remnant of IVS, thus confirming the diagnosis. In systole, there is common wall regurgitation in most of the cases. Differential diagnosis: unbalanced AVST should be differentiated from coarctation of aorta, HLSS, or tricuspid atresia based on hypoplastic right ventricle or left ventricle. Prognosis depends on whether it is associated with right or left isomerism, unbalanced AVST with small right or left ventricle, severe wall regurgitation, fetal hydrops, heart block, association with major cardiac anomaly or genetic syndrome. These all have poor prognostic signs. Long-term prognosis of isolated AVST is excellent with very low operative mortality. Surgery consists of reconstructing AV wall apparatus and closing the defects. While concluding the septal defects, I want to say dropout artifacts on grayscale ultrasound and overlapping of color Doppler can lead to false positive diagnosis of VST. The lateral and transverse view of a heart on grayscale ultrasound can be of help in reducing false positive and false negative diagnosis of VST. When the borders of VST appear echogenic, it helps in differentiating a true muscular VST from artifact. When a perimembranous VST is detected, detailed assessment of great artery is critical given the strong association with conotruncal abnormalities. When AVST is seen, situs should be checked because of common association with heterodoxy. These are the references from where I have taken the content. Thank you so much for your patience listening.